Afternoon and welcome to the Penn State College of Medicine COVID-19 in Regional Skilled Nursing Facilities Echo Series. We are delighted to have you join us for today's very last Echo session in this series. I hope you all have enjoyed your time with us. We have enjoyed learning about all things nursing homes, so we appreciate your attention. My name is Jessica Byler. I am a member of the Echo team and I'll be facilitating today's session. So before we begin, if you have not done so, please put your name and your email address in the chat function for our record keeping. Please stay muted unless you're speaking. So that's going to be *6 if you're on your phone or that microphone icon on Zoom. You may also use the chat for communicating. I will keep an eye on that. Feel free to put questions in the chat during the presentation. And we do encourage the use of webcams if you are interested, because we like to see all of your lovely smiling faces. We do realize that question and answer time is important. So we try to categorize the questions and address as many as possible during the session. But if there are some open items after the session, we will do our best to follow up with those. Please remember, no personally identifiable information if you are discussing any of your patients or residents. We are recording these sessions and we will share all the materials and recordings after the session. And in the spirit of Echoes, I'll teach, I'll learn, we will be on a first name basis during the sessions. Again, today's session, we will have a discussion on symptom management by Dr. Kristina Newport. And again, during the lecture, please feel free to put your questions in the chat and we will watch for them. And in the interest of time, we're not going to do introductions today, but I am going to turn things over to Christy and ask that she introduce herself, and then she can start on her wonderful presentation. All right, thank you all.
Thank you so much, Jessica. I really appreciate everybody's time. And I will ask that if you do ask a question, to please introduce yourself and tell us where you're from so we understand the context of the question. So I'm Kristina Newport. I'm the Chief of Palliative Care at Penn State Health. I've been here for 2 years. And prior to this, I worked in the Lancaster area in both hospice and palliative care, including visits in nursing facilities, assisted living facilities during that time. So that's my background experience that relates to some of the work that you do. So I'm really excited to be able to share some discussion about how you're managing things with patients. We want to focus on what are some of the common symptoms of COVID-19 that you might see in your residents. You are getting familiar with those. I think most of the lay public is familiar with those, but how do we manage those things? How do we manage things now differently than we might have before COVID? And then obviously offer opportunity for us to talk through these issues. So I don't have to tell you that this is a big challenge and that you all are really at the forefront of the work that needs to be done here. So you are already seeing that in our data. We see that the place of death for folks that have COVID is occurring most often in the hospital or in long-term care settings. And so we know that the work that you're doing is just so absolutely important, and that your patients are some of the ones that are at the highest risk for COVID infections and COVID deaths. So thank you again for the work that you're doing on this. We see, of course, that patients that get patients and residents that get COVID, they're more likely to die from it in the older populations. So when we're thinking about palliative care and how we do this in patients that have COVID, we really want to apply the same kind of principles that we apply to non-COVID people in this setting. And so one of the palliative care clinicians out at UCSF, I think, said this well when we say that we use the same recipe, it's just in a different setting and sometimes with some different tools. And our goal is to make sure that every person gets the right care at the right time in the right way. I think you've already had some discussion about, identifying people's goals and determining what they want in their care. And so today won't focus as much about identifying goals. It will focus more on how we actually administer the care for people. So you may be familiar, palliative care principles include really good understanding of illness and awareness of prognosis in any condition, as well as proactive planning. This includes advanced care planning and discussing, the potential need for things like hospitalizations. And then really at the core, the care that we deliver is interdisciplinary whole person care for any kind of distress. And so we will be going through those aspects of how they apply to COVID. So starting out with proactive planning, this is something that you are familiar with doing in your facilities, whether someone has COVID or not. One of the first things that you identify when folks come to your facilities is who are the decision makers for this person? Can your resident make decisions for themselves? If not, do they have both a financial and a healthcare power of attorney to do that for them? Understanding what it is that they want and don't want, whether someone wants to go to the hospital or not. And, we're finding that some people feel differently in the setting of COVID than they did before COVID. So there are some people that, that indicated that, oh yeah, I'd be okay going to the hospital if I have an acute crisis. And now in the setting of COVID, they're fearful of the hospital. And so they say they don't want to go. We also see the reverse, where folks that, said, well, I don't think I would want that, but, COVID, there's still so many unknowns, maybe I could get better, so I do want to go. So it does really necessitate another conversation about people's desires for hospitalization versus resuscitation in the setting of COVID. And certainly other components of proactive planning is helping both clinicians and patients to understand what their prognosis is based on their underlying comorbidities as well as COVID itself, and ensure that they understand that so that they can make decisions that are informed. So after those conversations are held and we really, understand what patients and families want, then we really look at, well, how do we make them most comfortable in the setting that they prefer? So we are going to focus today on the residents who decide that they want to stay at your facility. Either they're not sick enough to have to go to the hospital, or they've decided that they don't want hospital care and they prefer to stay in place and have their symptoms managed there. So this is really one of the early outlines of some of the symptoms that we saw with COVID. This was from a group in Italy that looked at the incidence of symptoms. So fever was most likely, shortness of breath and cough were the most bothersome symptoms in the beginning. So we're going to break down some of these most common symptoms and talk about how to manage those. So dyspnea management in COVID, although in the beginning we were really thinking of all different kinds of things, for our residents that potentially are in your facilities, we want to use some of the same principles that we would use in any other situation of dyspnea and shortness of breath. And so first we want to look at what are the underlying causes. Does this person have a comorbidity of COPD, and are they getting, the nebulizers or inhalers that they typically need? Are they sitting in a position that they're comfortable enough to be able to breathe well? Do they have air moving? Really getting at, first, are there underlying other causes other than COVID that are causing the dyspnea that we can alter? Is the patient hypoxic? So is their oxygen level low, less than 90%? If so, then let's look at, can we alter that? By supplying supplemental oxygen, we know that that can diminish people's perception of being short of breath, typically via the nasal cannula. Some people prefer to have the face mask, but often we find that the nasal cannula is the most comfortable for folks. If that doesn't alleviate their discomfort, and we've already addressed all of the different causes that we can to the best of our ability, then we potentially look at using a low dose opioid to try to decrease that sensation that they have difficulty breathing. Again, this is under the assumption that we've already done all of the disease-related things that we can. And so if the person has a pneumonia, we've decided whether or not they'll get antibiotics, we've initiated those, that kind of thing. But if we're at a point where we've already done all of those things and they're still dyspneic, then we think about bringing on the low-dose opioids. So you can see the kind of dosing tips on the side. And I want to point out, as Jessica already put the links in our chat, one of our national organizations, the Center to Advance Palliative Care, has really been leading the way in making resources like this available to everyone across the country. So typically they are a subscription organization, but they have made these resources available for everyone. So if anybody is looking for some guides on dosing, that you can pull this slide exactly down from CAPC and use it for yourselves. So dosing tips, starting low dose if someone hasn't been on opioids before, starting at a concentrated liquid morphine dose of 5 milligrams, giving it as often as every 2 hours as needed to help to relax that shortness of breath. And again, it's important when we're assessing for shortness of breath the dyspnea and shortness of breath is a subjective feeling, right? And so there are some objective things we can see, like is somebody breathing really fast? Are they using neck muscles or chest muscles to try to breathe? But it's also important that we simply ask, do you feel short of breath when we're assessing whether or not someone would benefit from these medications? We know that these can make people sleepy or confused. So we always want to use the lowest dose possible to try to provide relief, but not make their condition worse. So moving on then to one of the other common symptoms, and this is cough. So again, as in any situation, we always try to address non-pharmacologic tools that we have before initiating medications for this. And again, we want to treat whatever the underlying cause is. So if there are other causes in addition to COVID, we treat those. We try to manage secretions. We do find that if people are upright, that helps to drain some secretions and they have less cough that way. There is some evidence, at least in other causes of cough, that honey can be helpful. So that's a non-pharmacologic option. And then if it still is refractory after we're using really the disease-directed interventions, then again, we can use opioids to suppress cough. This, for some people, this is really the most bothersome symptom, and it can be very disrupted. So this can be a challenging one, frankly, to control, and can interfere really with quality of life pretty significantly. So fever certainly is another one that we know can be bothersome to people. It can lead to delirium and distress that way. So again, treat any underlying conditions if the patients are interested in doing that. So if there is, a concomitant bacterial infection, certainly treat that. Use of acetaminophen either from the oral or rectal route is a potential here. And then if people can't take those or that's not effective, using cool packs and using them under their arms or in their groin where it gets close to the large blood vessels can help to cool people down. And making sure that there is good air movement in the space can help to keep people cooler as well. Again, this is something that it's important for us to not just look at the numbers, but to look at whether it's making the person uncomfortable. So we're not just treating the number, we're really treating their discomfort from it. So, one of kind of the non-physical symptoms that really is present in not just our residents, but in our staff and our family members is anxiety, right? This whole situation has led to really a lot of fear of the unknown. And because of our need to separate and isolate, it's really led to loneliness and more fear as a result. And so it's really important when we're thinking about treating folks with or without COVID, frankly, is to think about how do we help to overcome this anxiety? And so, helping to have a calm presence. So, the people that are providing the care to the people right at the bedside is, to try to address their anxiety outside of the room so that they can be a nice, calm and therapeutic presence for residents. Initiating calming sounds, and that might be patient specific. So if someone really liked a certain kind of music or they like the outdoors, utilizing sounds of nature, those kinds of things to create a calm, auditory environment, including familiar pictures, things that make people feel like they're surrounded by their loved ones, and trying to ensure family contact in whatever way is possible so that they can, be getting support from their loved ones. This is also an opportunity and a role that our spiritual care colleagues can play, whether that's a clergy from the community or somebody within your facility. This is an opportunity that they can be helpful to both patients and families. And then, if you've been able to institute all of those various things and folks really still are significantly anxious, that's when we think about the anxiolytics. So, we certainly know that there are side effects that come along with these things, right? And so if we get all the way down to this point that we're using something like lorazepam, we do want to do this in an informed way, right? And so both the resident and family members know that this can make people more sleepy. It can exacerbate delirium, and it can put them at risk of falls if they remain ambulatory. But this is a tool, particularly very close to end of life, that might be useful if somebody is having extreme episodes of anxiety. I have to point out that that's different than delirium. So, delirium is when people have altered consciousness or confusion, and lorazepam or Ativan is not the best choice in that setting. So, one of the symptoms that really didn't kind of show up on a lot of our charts in the beginning of this illness, but we're seeing more and more of this as it kind of goes on, is arthralgias and myalgias. And again, this can really get at people and really make them uncomfortable, really kind of make them miserable. And so, assessing for this is important, just asking. And people might not describe it as pain because it's not necessarily just one really sharp pain in a joint. So people might describe it as discomfort or achiness. And so using some of those terms to assess it can be helpful. And so asking folks, do you feel that achiness? Do you feel uncomfortable? Utilizing acetaminophen again in the oral or rectal route, keeping people cool if there are joints that are particularly inflamed, potentially using topical anti-inflammatories in this. We don't have significant data to say whether opioids are beneficial in this case. We know that they can be helpful in other types of pain. So if you've already done these more conservative measures and people are really still having discomfort, that would be a consideration. And again, if people have severe discomfort and specific joints, you might consider systemic corticosteroids or very low dose gabapentin as well. Again, knowing in this situation that opioids, gabapentin have also the potential to cause delirium or sedation. And so keeping that as an informed process is important. Very rarely, we see some hemoptysis, so people coughing up blood, and this can come if the COVID is really causing significant inflammation in the respiratory tract. This is not something that's going to be easy to fix or to stop in a residential facility. So again, our role is really to help people to cope with it and to not cause more distress. And so being sure that your staff are aware that this might happen. It might just be a little bit, it might just be blood tinged sputum, or it might be a larger amount if somebody's on a blood thinner or they had pre-existing, a lung cancer or something like that, they may be more prone to this. So it's something that you may think about preparing for. It's kind of a simple trick, but having dark towels or fabric to be able to absorb blood that folks cough up can help to decrease anxiety about it, because nothing, is more scary than seeing kind of bright red blood in front of you on white towels. Again, in this situation, if there is significant bleeding, it's a situation where we think about using medication so that people are not as awake and alert and aware of that difficulty. But really, if this is happening, it really is a supportive kind of intervention. We're not likely to be able to stop it on our own. So if folks are really coming close to end of life, they're not awake or alert anymore, we often in COVID and in other diseases see difficulty with managing secretions. This is often referred to as the death rattle. And honestly, this, we think is likely more distressing to family and staff than it is to the patient. I always encourage people to look at the resident and see, does their face look like it's cringing? Do they seem to be uncomfortable? And typically it bothers us more than it bothers them. We also know, that while cholinergic medications are used to try to dry up secretions, such as scopolamine, glycopyrrolate, or atropine drops, we know that the evidence base actually directs us to repositioning the patient as the most effective way to help to decrease secretions. And so either putting the person sitting more upright or turning them hard to one side is actually one of the best ways to try to decrease those secretions. And again, reassuring both staff and family that although it can sound terrible and distressing to us, this typically is not something that the patient is uncomfortable from. By the time this happens, it's because they are so sedated from their illness and they're so unaware that they're weak and they're not swallowing their secretions like they normally would. So this typically does not cause distress. So delirium certainly is something that I know many of you are already familiar with. And we always want to emphasize first is to try to treat that underlying condition. We know that any kind of infection can lead to delirium, particularly in somebody that has some underlying dementia or cognitive impairment to begin with. We always, again, want to start with our non-pharmacologic interventions. Make sure their bowel and bladder are moving okay. Make sure they have their hearing or vision aids if they need them. Make sure that our lighting is appropriate for the time of the day and the time of the night. Make sure that our sounds are not keeping them awake and impairing their sleep, and keeping them as oriented as we can to the time of day. If those things are not effective, and particularly in the setting of COVID and associated delirium, then we may consider pharmacologic interventions. It's pretty rare, but there are some situations where delirium is the most distressing symptom. And as people are approaching end of life, in some rare circumstances, we do need to use medicines to sedate people so that they do not harden themselves or can, cause significant distress very close to end of life. So I wanted to share this. Again, this is available at the CAPC website. And this is kind of a whole chart that gives you some of the appropriate dosing for some of the medicines that I talked about for the various symptoms. So this is something, if you haven't already done, you can take with your pharmacy colleagues to be able to say, do we have good access to these? Do we have them in the Pyxis already, or do we have to get some things ahead of time? So these are some of the medications that if you don't already have them available, I would encourage you to think about, making sure that you can have these quickly available if you do need them for your residents. So moving from the resident physical distress and their anxiety and thinking about the family, right? So that's really part of what palliative care does as well, is also think about caregivers, staff, and family. So how do we try to manage their distress? We know that this has been a huge part of what you've been having to work with, even with folks that don't have COVID, trying to communicate with the family. We know that families feel better if they do get regular medical updates, if they have that opportunity to ask questions about what's happening with their loved one, and if they have the ability to communicate with their loved one. The other really important point in residents, if they're going to die from this condition, is to try to facilitate some kind of goodbye with their family. And certainly you need to adhere to your, any kind of restrictions for safety in your facility. But there are certainly opportunities to be creative with how family can have a meaningful goodbye with their loved ones, how they can perform things such as life review, being able to share the important things about their loved one and what that person means to them, and to be able to perform any rituals that are meaningful to them. Sometimes these are related to their religion. Sometimes it's just a family tradition. Sometimes it's things like, getting a thumbprint or getting a lock of hair. And so being intentional about engaging with family to say, what kinds of things might be important for your loved one in this setting. And then also being intentional about identifying when the person is close to the end. And if it's consistent with what they or their family indicate, trying to be sure that they're not alone at the very end, whether this is, an aide that can sit with them or somebody from hospice that can be with them. It's an opportunity to be able to reassure family if they think that that's important to their loved one. So I also wanted to point out, I'm really been focusing on people that we think will die from the condition, perhaps in your facility, but I also think it's important to point out the growing evidence that we have about symptoms that can linger in people who have recovered from COVID. And so because this is something that we'll all be dealing with for possibly a significant amount of time. And so one of the main symptoms that we see is fatigue, continued shortness of breath, joint pain, then chest pain and cough are some of the most prevalent symptoms that we're seeing. And so, thinking about how do we assess for those things, how do we continue to manage those as time goes on is another important thing to recognize and to relate back to the original diagnosis and think about how to support our residents. So I wanted to jump then to, if you do have folks in your facility who have decided not to go for hospital care in the setting of COVID, just wanted to talk about hospice. And my guess is that most of you are already familiar, but we always kind of start at the beginning when we're talking about hospice services in case there is somebody participating who's not familiar. So hospice care in general is a multidisciplinary type of care that is provided for people who have a prognosis of less than 6 months and desire only comfort-based care and not interventions that prolong life. So they provide, as I said, a multidisciplinary team. It's led by a registered nurse. It also can include home health aides, social workers, chaplains, and in non-COVID times, typically volunteers. Now the volunteers are kind of behind the scenes and they're not able to do as much patient care. It also includes coverage for any medications that are necessary to control symptoms, as well as medical equipment, including potentially oxygen, hospital bed, those types of things that someone might need to be comfortable. The other added benefit is that it provides support to family or caregivers and bereavement support after the resident dies. And so this is an ongoing support. You may also note that if they are in your facilities, that they also provide support to staff. And so that can be really valuable in your residents' facilities. So, kind of back in the beginning, it was a question of, can hospice be provided for folks with COVID-19? At this point, most hospice agencies in our communities have identified ways that they can safely care for folks with COVID-19. And so it is available in most of our communities. It can be done in home or in a residential facility, with or without hospitalization. If you haven't already, established relationships with the organizations that are able to accept patients, that's certainly something to do proactively, and be understanding and aware of what their policies are in terms of how they test their staff and the patients that they care for. Then the question, if you're allowing someone to come in, is it safe? And you all certainly are working through your regulations of who you allow in or not. And so you're probably better versed on that than I am, but certainly the hospices are aware of the, all of the regulations that they need to apply, and to make sure that they're not, making the situation worse in your facility by any means. So the differences really in the current setting in terms of hospice care in the setting of COVID is that there have been some relaxation of some of the regulations when it comes to hospice delivery. So you may be familiar that there are some hospice regulations about required face-to-face visits with physicians or nurse practitioners in hospice, and Medicare has allowed those to be changed to telehealth or virtual visits. So to try to decrease the need for face-to-face visits if it's not really medically necessary. You may also see that hospice organizations will work with your staff to try to decrease the need for, frequent visits in the facility if possible, based on what the residents' needs are. And in doing so, they may decrease the home health aid, coming in and out of your facility. In most cases, hospices are having their social workers and their chaplains do virtual visits, either with the family or with the resident, so that, again, they can decrease that face-to-face presence. But they certainly do have the ability to make in-person visits, and they should be providing the PPE for their staff to do that. So again, we talked a little bit about how the hospice may be able to contribute to supporting and providing bereavement for your own staff and your residents' facilities, because this is a hard time for everybody. And our hospice partners are experienced in providing grief support and staff support in this situation. But certainly it's also valuable for them to have, for families to have that added bereavement support moving forward as well. So, certainly if you haven't already collaborated with your regional hospices, that's certainly something that we would encourage you to do. If you have trouble tracking down hospice organizations, you can reach out to us. You can reach out to the Pennsylvania Hospice Network. That's something that every resident should have access to if it's in alignment with their goals. So again, just to point out that there are numerous options for resources in addition to those that we've talked about here. But I would encourage you, if you need some directions on medications, or even if you want to provide some training for your staff, the Center to Advance Palliative Care does provide online training modules that can help with communication, discussing whether someone wants to go to the hospital or not, and also providing training on using some of these medications that perhaps clinicians in your facilities were not accustomed to doing before. It helps to walk through some of the basics of symptom management. So all of those things are currently available free of charge for anybody to be able to access. So takeaways from all of our discussion, we have to think about managing distress for both the resident, the staff, and the family. And that's both physical distress and, the mental distress that comes along with this condition. We apply the same kind of principles that we do in the non-COVID times, and certainly encourage you to involve hospice when that is consistent with the residents' goals. So I'm happy now to hear what your thoughts are, what your experiences have been, and to take any questions. I wonder if anyone has any experiences of having difficulty, having discussions or managing symptoms with any of your residents that have had COVID. You must all be doing a perfect job.
Christy, it's Nikki Asavala. I
Hi.
actually haven't personally managed residents with COVID, but we're in buildings, and there is, whenever there is any sizable outbreak, death many times in individuals who had underlying conditions, but sometimes unexpected as well. And the one aspect I think that you brought up is kind of the emotional burden on the staff, who, especially in long-term care, where they're like family, the staff know the residents really well. And, for those who have underlying conditions, perhaps this was something that just kind of brought their life to an end sooner. But there have been instances where there were residents who likely had, many more years, even decades to live, that died suddenly. And so we've actually seen, when we're out at our site visits, many asking for mental health support for the staff. And I think a lot of it does revolve around not only the stress of having a COVID outbreak in the building, but also the resident deaths that they're experiencing.
Absolutely. No, and you're totally right that staff in the facilities often are like family, and they may have been taking care of people for years, and they're really a part of their intimate day. And so it really is a significant loss. And Nikki, you could probably comment better than I could about, general mental health support that might be available. But I would encourage folks, if, particularly when it comes to the death of a resident, the hospices in our communities, they are tasked not just with caring for the staff and family of those who died, but it really is part of their mission to provide bereavement support, for community need in general. And so particularly the nonprofit hospices in our communities often will be willing to, come and support staff, and even do, specific sessions, or help you to, kind of have some rituals for staff to be able to remember people. I can say that, one of the things that our team does, because, obviously we have a lot of folks that die that we care for. Every week we have a tree that's up on the wall, and we put leaves on the tree with the names of the people that we've cared for. And it's an opportunity for us to just talk about that person, not about their medical condition, but about who they were. Sometimes how they've influenced us, how they've influenced other people in their lives. And, a simple thing like that can be a really helpful again, ritual or just process for staff to be able to go through, so that they can honor the lives of the people that they've cared for and really share how that has impacted them. So that's, a simple, no cost thing that can be instituted in facilities, that can be done, in huddles, in care groups, and nursing pods, to be able to reflect and honor the people that they've lost. Have any of you faced
The other
challenges?
thing, and this isn't
Go
so
ahead,
much about
please, Nikki.
symptom management, but I just reflect on this with within the group, is with the staffing challenges that our homes are under right now, and caring for someone at end of life. I do worry about what the acceptable level of staffing is versus what is really appropriate when you have residents who have a lot of symptoms related to their COVID infection, and especially those who are near end of life. And I know many of our homes have struggled with this because, normal staffing in a nursing home is not suitable to meet the needs of symptomatic residents. And I don't know if anyone that is on the line is willing to comment on that, but we've really seen a huge uptick as the outbreaks have increased in the area over the past few weeks, of calls for staffing support. And I think a lot of it is that feeling of, we should have enough, but it doesn't feel like we have enough. We feel like we're struggling to keep up. And I do believe it is in part related to just trying to keep on top of the resident symptoms.
Sure, absolutely. And then that's a terrible feeling for staff to feel that maybe they're not meeting needs. I would be interested to hear how any of you on this call have responded to that and how you've reflected on it.
Silence.
So either you're all out helping your staff respond to needs or not having challenges. Has anybody had troubles with the medications that you need or collaborating with your community partners to get what you need for your residents?
Well, this is Janice Whitaker. I'm with the Penn State College of Nursing, the Center of Geriatric Nursing Excellence. And I had served as director of nursing in a skilled nursing facility for several years prior to working at the college. And in reference to the comments in question about staffing, I'm actually real hopeful that, at some point when we evaluate, what has occurred with COVID, that it would highlight an existing problem for a long time, which is the very minimum standards, for staffing. And that it's a real challenge, and hopefully there will be some support, financial support and other types of support for nursing facilities around staffing, because the minimum standards, in terms of nursing hours are very low. And, most care communities that strive for excellence do everything they can to be well above those minimum standards. And even then, there are many challenges in terms of really providing care that meets, the psychosocial needs of a resident in addition to their physical needs. I found that when staffing was not ideal, nursing assistants and other members of the nursing care team had everything they could do just to toilet everyone and reposition everyone and help to serve and assist with meals, let alone, spend time holding someone's hand that is, passing, or spending time, with a grieving family member, and that's where we need to get to be. And the other big piece of that is it's not just about numbers. It's also about, the training and education and making sure people have the type of support they need. Another aspect of staffing is registered nurses. Most care communities need more registered nurses to do the level of comprehensive assessments and working with clinicians that's required. The acuity level is very high in a skilled nursing facility, and the number of RNs required is, again, can be quite minimal. We were fortunate that we had administrative support to put more than what was required in terms of RN staffing on duty to meet the needs. But that's not always the case, and not all care communities have the resources to do that. And then the last thing I'll just say is I do think there are some cultural things that care communities can do until we get to that point where the numbers are increasing in terms of staff. And that's really a real team-focused approach to care, that everyone that works in the care community provides care at some level for the residents that reside there. So, enlisting the support and colleagueship of the activities department, the dining services, finding ways that non-licensed personnel can support staff. One quick example is that I found that my evening shift had difficulty because the phone was ringing a lot. They didn't have anyone to answer the phone while they were on duty. So we did get a receptionist available, but we also enlisted the support of the activities department during mealtime. So anyways, I could go on and on with lots of examples, but I do think I'm one positive outcome I'd love to see, and we have an opportunity to advocate around this, I believe, is trying to work with legislators and other decision makers around finding ways to support nursing homes and skilled nursing facilities with better staffing.
I'd like, this is Mary Ann Choclos. Can you hear me?
Yes.
Okay. I've been in long-term care for many, many years, started back in 1984. And I can honestly say in my career, I have never experienced anything like what we're experiencing currently.
Yeah.
And I think that, when it began back in March, we all thought this was going to go away. And we did a lot of things and the community rallied around everybody. But I think that at the end of the day, when it started to get calmer, I don't think that the staff that works in these communities and are not only dealing with COVID, but they're dealing with residents who have not had physical contact with their families in months. So they're not only taking, the fact that some of their residents who they have loved and been part of for years are passing in front of their eyes. In the beginning, we had a lot of deaths here back in March, April and May, and those staff never had the ability to grieve themselves. So then on top of that, we're putting, which we have to, strict things on them so that we prevent the exposure to other residents. And in some cases, we are pretty much saying to them, you brought it in because our residents haven't been anywhere. So I think that, we talk about legislatures and we talk about everybody in these buildings right now, and I can speak for the facility I'm in, are doing everything they can given the circumstances. We have the PPE, but it's an emotional roller coaster for, the dietary staff, the activity staff, those caregivers. I have the ability to have RNs on board, but if you're a person in the community looking for a position and you hear nursing homes, we always get the bad light. And how attractive is that to someone who's starting their career? As an administrator, I say to myself, I've stayed in this business for a very long time. I love what I do, but it's very disheartening when you've come so far from April till now, and it's become punitive to nursing facilities. It really has. And I don't say that in a, I say it in a little bit of a frustration way, because we're dancing as fast as we can. The staff themselves are coming down with COVID. They're worried about their families that they go home to. And on top of that, a lot of people don't want to come to work. They're fearful. So we're dealing with, so many different emotions that, the numbers, are there, but trying to get the people to want to come into the industry and understand that it's a good career choice. But I don't think we give that advertisement in the things that you read about long-term care. And I think, all of that impacts what we're trying to do. I've seen staff sit with a family member, with a resident and cry with them. Those are the kind of things that people don't see. And that is, that's often time on their own that they do it. So, I just think it's such a bigger picture in a sense of how do we make this right?
Absolutely. Marianne, thank you so much for sharing that experience that you've had. And you're right, your staff are dealing with their own risk of illness. They're often dealing with their own family members and school or job issues, in addition to facing these really difficult things in their workplace. Can you comment on what you have done to try to help to retain the staff that you do have and keep them healthy, in terms of their own mental health?
Well, we in the beginning when we had support help for them, we had the National Guard provided support. We have National Guard here now helping us do the testing, because that's a big to do, and that I thank that to Dr. Osavala and her group who helped us there. I have staff that have PPE fatigue. I just had a conversation, instead of being punitive, let's be positive. You wore your mask, you have your gown on, you did all the things right, trying to do those things. It's, they would love more money, and we did that in the past. Unfortunately, we don't have the availability to continue certain programs that we had. So just offering the support, having a food truck come in, the community thank yous, listening to what they have to say. I initiated a bead program where we give beads out, and then we'll, recognize the employee, just some kind of positive. But at the end of the day, they don't want to come off the unit to have, we give them food. Food is a good thing, but, they're rushing back with their, they're not allowed off the unit in some cases. And in other cases, they're running back to the unit because they have other things to do. So I don't know if there's a single solution. We've tried a lot of different things. I don't think we're 100% successful on any of those at this point in time. I wish I had that magic answer.
But certainly your intentions and really working to try to address those things is notable. Are there other folks that have tried to institute things like Mary Ann to help the staff? Or do any of you have other questions for how Mary Ann has done that, or what other challenges they've faced? We have a message in the chat to say, from Kathy Lenig, our facility does not have any positive COVID cases. We're trying to be proactive with preparing rooms, additional medications, and trying to think of anything we may need to assist residents. Staffing is not ideal, and if we have a positive COVID resident, I think the staff will panic. How do we support the staff and have them care for a COVID positive resident without fear? I'd really like to hear input from the group with those of you who have experienced this, thinking back, those of you who have had residents in your facility who are COVID positive. How did you approach that right in the beginning, or looking back, what advice do you have to Kathy to help prepare the staff the best?
One of the things that we did in the very beginning is to, and I think it's ongoing, is to make sure they know how many residents that has come out, how many staff. I mean, you can't say individually because of HIPAA, but that has been something that our staff has asked, how many. And because we had quite a few in the very beginning. I mean, back in the early months, it was just overwhelming. This time around, I think that we were better prepared. There's still frustrations because one person's telling you to do this, one person's telling you to do that. I think just talking to them and, giving them the numbers, trying to keep them on top of how many you have positive. And also just, I found sometimes I've had staff that come in here and just want to vent because I know I need to vent sometimes. But I think being honest with them and being prepared, and I don't think any of us are always 100% prepared. And then when it does strike, make sure that they understand the importance of all the PPE, because I think we all think it's not going to hit us. We went through our share, it's not going to come back. Well, it did. And, one of the most important things I think I would say to anybody who hasn't experienced it is talk to your staff and tell them, wash your hands, when you're out in public, understand that your impact of what you do outside the facility can impact those residents that you really care about. Because realistically, we bring it into the building. We can't now say, oh, they were out and the families brought it in, for us, any one of us, because most people have been asymptomatic.
Right.
So just, talking to them and preparing them because it's it's a scary, scary time because there's so much unknown.
Absolutely. Thank you, Miriam, for sharing that. And I would echo the things that you've said, those important points of maintaining transparency to the best of your ability and maintaining open lines of communication. We found that to be the same principles in the hospital when we're caring for folks with COVID. I wonder, Marianne, if you could comment at all. You've shared, certainly the burden on staff and then the need to have this communication and time for venting. How do you balance those two? The needs for there always being work to do, but then there always needing to be the time to be able to vent and to share information. How do you balance that out? How do you intentionally provide that space and communication?
I'm not sure that we found that balance yet. I really don't.
It's a work in progress, right?
It really is. I mean, I can tell you from an administrative perspective, excuse me, for me, the day-to-day things that I have to do as an administrator related to COVID, my days don't end sometimes till 7:30 at night because of all the reporting that we need to do. And then to be able to find the time to spend with the staff. Again, the staff, when their day is done, they want to get out. So that balance has not, other than just going to the units and trying to have a couple of minutes to them. One of the things that is if something's not there for them to go get it for them. Like that was a big deal here. We don't have any more of shields back here. Well, I went and got them for them and that meant so much. It was just, to me, it didn't mean a lot. I would walk to a place and brought them back, but to them, it meant they could clean that shield or whatever it was that they needed at that time.
And they were being heard. You were acknowledging their need.
I wish I could do it more often. I wish I could spend that time with them more frequently. I don't feel like I do that as much as I would like to.
This is Janice. I haven't experienced the COVID pandemic in a skilled nursing facility, but part of what Marianne is describing, and I know I experienced with other, challenging situations. A lot of it comes down to, the communications infrastructure you have in your organization, and some of it is structured, so whether it's during rounds or huddles or routine opportunities to connect with staff, such as staff meetings, which may be challenging to implement right now. But I think if they know they're going to have these opportunities to get information and ask questions and share their concerns, that's kind of a proactive thing. And then, even providing resources, whether they're written or they pop up in the EMR when they go to chart, can also be a way to disseminate information. And then, as Marianne's describing too, that open door policy that the leadership team really needs to have to allow people to come in and express their concerns. The one specific idea I'd like to offer to Kathy is, maybe you like to use a proactive approach at your facility, which is wonderful. Maybe try to identify a few champions that you think on your nursing team or other caregivers that might be interested in some additional training. Maybe they even get, a little boost in their pay. And that they are taking a lead so that when you do have that first patient, with COVID, that, and of course you'd have to make sure you address all the different shifts and pull this team together, but maybe they have some, unique leadership abilities and some unique training, and they can kind of serve as role models and then champion the rest of the team. then the last thing I want to say is I think that a lot of facilities, when we were talking about mental health challenges as well as other stressors, we really need employee assistance programs. And I know I worked for a for-profit organization and we did not have an employee assistance program. And so, there's multiple things coming at an individual employee when they're working through a crisis like this, but they also have stressors outside of work as well. And, an employee assistance program can be, really helpful if they're dealing with financial troubles on top of this, or childcare issues, or, any number of things. So I think that would be another layer of support for employees.
Thank you, Janice. Does anyone else have any other comments or thoughts about supporting staff and maintaining appropriate PPE usage?
Yeah, there's notes in the chat about PPE fatigue.
Right. Yeah, and I think, it's really a great point is wearing the PPE in the facility, but also really impressing on staff and any really healthcare providers that the way that we act outside of our facilities is also super important, and that it's a heavy responsibility that we all carry to know that we can put our residents at risk. So we'd really appreciate all of your time. We know that this is an hour out of a very busy day, that you're trying to do all of this work that we're referencing. And you've all impressed on me that, providing good symptom management and support to our residents really starts with supporting our staff. And, we've heard good points about using this current situation to really advocate for appropriate ratios of staffing, but also when we're in the thick of it to try to take the time to intentionally do some of the things that we heard about today to both recognize and support our staff in the ways that are needed. We can't take care of someone else if we're not taking care of ourselves. So thank you so much for all of the work that you're doing. We're so glad that you took some time to collaborate and hear from us.
Thank you, Christy. And thank you, everyone, not only for your engagement today, but throughout this whole series. We hope that we will be able to connect with you in some of our future ECHO series on COVID, and this information is still really relevant, and we just thank you. So you will be receiving the email shortly. I also put it in the chat that has the link for the session evaluation. If you are claiming CME credits, you do have to complete that evaluation. If you have any comments, we will send a final session or series evaluation to you. We do actually really read those, I promise. And we use that information to help improve our ECHO sessions in the future. So I know it's extra time, they're pretty short, but if you would like to complete them, they're very appreciated. And this is our last session, so we don't have any follow-up for you. But again, please reach out to us if you have questions, concerns, or need anything else. And I will give everybody a couple minutes back in their day. Thank you, Christy, for a wonderful presentation.
Thank you all. Keep up your good work.
Thanks, Christy.
Take care, everyone. Be safe.